Today's topic is the NEMSIS Pre-Hospital Blood Resources and Tools. We're honored to have Jeremy Kinsman from NHTSA and Randall Eimerman from NASEMSO, and then, of course, our own Kevin Nicholes from NEMSIS. And they're going to be showcasing the national efforts to advance pre-hospital blood transfusion programs with data use, improving access to resources, and promoting guidance across the EMS community. With that, I'd like to turn the time over to Jeremy. Go ahead and take it away.
All right, thanks, Chris, and thanks everyone for joining today. I'm Jeremy Kinsman. I'm an EMS specialist with the NHTSA Office of EMS, where I serve as the federal program manager, federal NEMSIS program manager, and lead up our office's research and analytics initiative. So I'm excited to present today on several NHTSA post-crash care and kind of pre-hospital blood initiatives as a lead-in to a lot of the great work being done by our partners at the NEMSIS TAC and of course NASEMSO. So for folks who aren't aware, our Office of EMS at NHTSA, we've administered and funded the NEMSIS program for the past 20 years, which all of you know is housed and operated by the NEMSIS TAC team at the University of Utah. And so our NHTSA initiatives direct a lot of the work that the NEMSIS TAC does, and it's a great relationship again that we've had for our partnership and relationship we had for the past 20 years. So it's great to see how initiatives coming out of NHTSA are supported by the tools and resources that the NEMSIS team develops. And so, of course, this includes, our current initiative on kind of advancing post-crash care countermeasures like pre-hospital blood. So let's start by just kind of looking at some of the data. Many of you may have seen this statistic before, but I think this does a good job of helping us to understand the scale of the problem we face in post-crash care. So according to NHTSA's fatality analysis reporting system, or FARS data, we know that in 2023, nearly 41,000 people died from injuries sustained in a motor vehicle crash. However, 43% of those fatalities were still alive at the scene when first responders arrived, but they ultimately died within 30 days. So for 2023, that's roughly 17,000 patients. So I think, our goal is really to try to understand, we know the motor vehicle crash ultimately led to that patient's death, but it's to understand more about the patient's mortality, what was ultimate cause, what was their kind of ultimate cause of death, what were their underlying causes of deaths, and how might optimal EMS and trauma care might that have prevented their deaths. So, of course, this includes pre-hospital blood, which we know has been demonstrated both anecdotally and in the research literature to save lives of patients in hemorrhaging in the pre-hospital setting. We know for a fact that severe bleeding is a primary cause of preventable fatalities in trauma patients. We also know that time is absolutely critical. Our research shows that every single minute of delay in administering blood increases a patient's risk of death by about 11%. And so by kind of bridging this gap, we know that pre-hospital blood has the potential to save, 37% of trauma patients with severe bleeding. So, another way to think about this, I think it's also important to point out that our intent in illustrating this 43% number is not that it's not to lay blame. I think it's about identifying opportunities for improvement and identifying, how resources and innovative practices can help our EMS systems across the country to save these patients' lives. Looking at our FARS data by state, this is data from 2019 to 2023. So that 5-year period of data, we can kind of see how that 43% number, again, 43% of motor vehicle crash fatalities where the patient was alive at scene, we can kind of see how that varies across the country. So, our data shows that roughly 2/3 of these cases occur in urban areas compared to about 1/3 in rural areas. States with densely populated urban centers tend to have a higher proportion of these patients found alive at scene, and that might just be a function of how quickly EMS is able to reach the scene after the crash. And so I think this dynamic, it really kind of highlights the critical need for immediate action after a crash, immediate activation of the 911 system, the use of emergency medical dispatch to ensure that appropriate resources are dispatched, and then, of course, a timely response by our first responders and EMS. So I think this really serves as kind of a reminder that while clinical innovations like pre-hospital blood um, can save lives, the success of that innovation really depends on a well-resourced and well-coordinated 911, well-coordinated 911 and EMS systems. So what are we doing about this at NHTSA? Improving post-crash care. It's a critical national safety priority. Um, Pre-hospital blood was recently named one of 8 federal priorities in our administrator, Jonathan Morrison, in his Pathways to Safer Streets Action Plan. So to tackle this, NHTSA and our Department of Transportation, we've committed $37 million to expand post-crash care and pre-hospital blood transfusion programs over the next 3 years. And this really represents the largest federally sponsored pre-hospital blood transfusion project undertaken. What are we specifically looking at in our office? So these are our Office of EMS strategic priorities for 2026. We really have 3 main goals. One, to expand access to pre-hospital blood. And so that's specifically looking at increasing the number of U.S. counties with pre-hospital blood programs and access from 147 back in 2024 to about 250 in 2026. The good news is, as of March of this year, we've already surpassed 350 programs. So we're doing well on that metric. We're also really focused in on pediatric care. So we really want to see the increase in the percentage of children in shock or hemorrhage after a crash who received pre-hospital blood transfusion from 1% to 5%. And then obviously bystander intervention and emergency medical dispatch as well. We want to increase the delivery of 911 pre-arrival instructions to bystanders and to our first responders as they're en route. So according to our NEMSIS data right now, that's been hovering around 16%, and we really want to increase that up to 2025 this year. So we really are seeing tremendous progress nationwide. So pre-hospital blood transfusion programs, we've seen about a 270% increase over the past 2 years, going from about 100 programs in 2024, again, to about 350 programs to date. And these programs are, they've been implemented in rural, suburban, and urban agencies across 41 states. So this is not something that's just limited to urban areas anymore. We are starting to see, again, expansion into those rural areas. And this credit, I think, really goes to our EMS agencies, to our state offices of EMS, to our partners at the Pre-Hospital Blood Transfusion Coalition, have been doing a lot of just great work in this space to get these programs expanded across the country. One additional thing that I want to highlight that we're doing at the U.S. Department of Transportation, to help secure the resources needed to expand these programs, I want to highlight the Safe Streets and Roads for All, or SS4A grant program. DOT is really placing a priority on public safety infrastructure, post-crash care, emergency response coordination, and pre-hospital blood transfusion activities in the FY26 funding opportunity for the Safe Streets and Roads for All grant program. So these were activities that were previously eligible, but now they are being highlighted in the FY26 funding opportunity. And applications that have one of these elements, public safety infrastructure, post-crash care, emergency response coordination, pre-hospital blood, they are going to be rated higher. So for FY26, there's about $1 billion available. Time is of the essence here. The deadline to apply is May 26th, which is just 3 weeks away. Our eligible entities include metropolitan planning organizations, political subdivisions of a state or territory, like a county, city, town, a special district, and some transit agencies, and of course our federally recognized tribes. Private entities and state entities are also eligible as subcontractors. So this is an incredible opportunity. I really encourage folks on the call today to access the SS4A website via the QR code, just email questions, and to reach out to me and folks in our office if there's anything that we can help with to support you in this space. And then just to further kind of highlight, I think, how over time SS4A has increased their funding, has increased their awards for post-crash care and pre-hospital blood. If you look back at the first year of SS4A back in fiscal year 2022, there was roughly about $200,000 that was awarded to post-crash care and pre-hospital blood programs. That has steadily increased, or exponentially increased really over the past 4 years. We're back in FY25, we had $83 million that were awarded at SS4A for post-crash care and pre-hospital blood. And our expectation is that is going to continue to increase for FY26. So again, please visit the website and reach out with any questions. An additional thing that I just want to highlight here that I know Randall from NASEMSO is going to go into some detail about, but it's just expanding these programs successfully requires kind of standardized data collection. So when pre-hospital blood started expanding really over the past 5 to 10 years, our NEMSIS data standard wasn't set up to allow for kind of the comprehensive data documentation that was needed for pre-hospital blood. And so we've done a little bit of catching up. And so NASEMSO has done, the Data Managers Council has done a great job of putting together this blood product documentation, this guidance document that really describes in detail how blood transfusion by EMS should be documented using e-medications and e-procedures fields and some other fields as well. And so when those fields are used, that is particularly beneficial for our state office of EMS and us at the national level. It allows us to kind of track, where blood transfusions are happening, where EMS is doing blood transfusions, where we have opportunities for improvement. And that's important information that we can provide to, state leaders and federal leaders to kind of show the impact of these programs and, can, I think, illustrate where we might need to allocate some additional resources. Just a couple more slides for me here. I just want to kind of bring us back to why this is important and talk about a specific case. So this was a case that was highlighted in the news media. So it's okay for us to share the details here. But this was in Colorado. There was an 8-year-old male pedestrian struck by a vehicle. And he had a blood pressure of 58/43. His heart rate was like 160, an elevated respiratory rate. His shock index was 2.76. This is a patient who, likely would not have survived without pre-hospital blood. And within 7 minutes of being struck, pre-hospital, this child being struck by a vehicle, pre-hospital blood was being administered by the Colorado Springs Fire Department. So just an incredible story here of a child who likely without pre-hospital blood, again, would not have survived. They administered 2 units of whole blood. Then he got an additional blood at the hospital, and 2 weeks later, he was discharged. So, this is really why the pre-hospital blood initiative and the post-crash care initiative coming from the Department of Transportation and NHTSA in our office is so important. And that's why, we're working so closely with NHTSA, the NEMSIS TAC and the NASEMSO on the resources and tools that they're going to go over here shortly. So just an ask to you all, what can you do? Please identify high need counties and communities that really need pre-hospital blood. You can work with us. You can work with the NASEMSO, with the NEMSIS TAC. You can work with the NASEMSO to identify those areas. You can work with your EPCR vendor. Please work to kind of strengthen your highway safety relationships. Please apply for SS4A if you're eligible. Again, the deadline is May 26th. We encourage you to to continue relationships with your 911 leadership, to see what you can do to improve kind of integration between your EPCR and your CAD, and see what we can do to improve emergency medical dispatch, improve arrival instructions, and make sure that we're getting blood to the scene. And then, of course, as I mentioned, the NASEMSO DMC pre-hospital blood documentation guidelines. Please do what you can to kind of follow those. I know we're going to have some great presentation on resources from Randall and then Kevin, but also just wanted to point out to folks, we do have some Office of EMS, NHTSA Office of EMS resources available via the QR code there. And with that, if you would like to contact me, you can via my email address there. And I'm going to stop share and then hand it over to Randall.
Thank you, Jeremy. So kind of the next portion here, we're going to really be highlighting the data elements for the blood collection. So starting off here, we have our we have our EMS data section here for the e-medications group. Great ability to collect most of the information. During the evaluation process, we identified that some more data elements needed to be created to finish the blood collection. Those were created as national custom elements, and we will review all of those today as well. So the first thing to highlight here is really just our e-medications 03, our medication administered data element. But blood is documented as a medication. Typically in the e-medications 03, the accepted code type is an RX norm code for the medication. However, blood products are described through SNOMED CT codes, and NEMSIS does allow 7 blood products to be recorded in the e-medications field. It would be administration of a blood product, transfusion of a cryoprecipitated, transfusion of a fresh frozen plasma, the administration of albumin, intravenous blood transfusion of platelets, transfusion of whole blood, and the transfusion of packed red blood cells. Next, kind of going over the national custom elements. First, where to locate them. From the NEMSIS homepage, you can go to the technical resources. We'll drop over to the custom element library. Here, scrolling down just a little bit, you can see that there's a link for the national custom element list. By selecting that, you'll see a lot of other custom elements in there. But scrolling down, we're going to be starting at e-medications 905 and then working through e-medications 910. While this finishes up, the other portion that we're going to also discuss will be from the same page here, which is really just more of an informational resource on the blood transfusion national custom elements. It's a 2-page document that just sort of highlights the different blood transfusion elements, additional medication elements, and then the procedure and medication codes and EMS labels. So jumping right into it here with the national custom elements, there are 4 national custom elements that are specific for the blood data collection, and then 2 additional custom elements that were just sort of identified for additional details when documenting not just blood, but any medications in general. We'll go through each one of them in more detail. So first one here is e-medications 905, which is the blood product unit number. This is the unit number or a donor identification number, the DIN, of the blood being transfused. It's a federally required unique identifier that allows hospitals and blood banks to know exactly where the blood donation come from. This blood product unit number, it should be exactly 13 characters long. This one here, the numbers do go a little bit out of order, but I did want to group them together, is the blood facility ID number, or the FIN. And the FIN is the code that is assigned by the ICCBBA that identifies the blood collection facility that supplied the blood being transfused. Once again, this number should be exactly 5 characters long. So for the blood is the blood, or I'm sorry, e-medications 906 or the blood donor type, the ABO. And it simply is just the type of blood that's being transfused. This does have the field values A, B, AB, and O. Next one along the lines is the e-medications 907, which is the blood donor RH factor. It's just the RH factor of the blood being transfused. Field values here are negative and positive, also with not values if there is no RH factor. Next two data elements here are really more around medications, but became very valuable as we were sort of exploring the blood data collection. The first one is the date, the time the medication administration was stopped. So existing current NEMSIS standards allows us to document when the medication was started. Now you're actually able to document when that was stopped. And the last one here is e-medications 910, which is the medication status at the patient transfer of care. This would just be another way of identifying what the status of that medication was when you decided to transfer the care of the patient. The highlight here of just that informational document that we saw, you're able to follow the video from before to find it. It is under the custom element section of NEMSIS, but just a two-page document that really highlights the custom elements that have been created, the procedure codes, and the medications. The next slide here is the guidance document that Jeremy had referenced earlier. If you scan the QR code, it will take you directly to the Data Managers Council page. This is a great document. It was put together with the data managers working with many other EMS stakeholders. But the purpose of this guidance document is to provide states with the standardized method for documenting blood product usage, which will facilitate a more robust data collection and analysis. Implementation of this guidance will ensure consistent and reliable documentation as well as parallel reporting at the local, state, and national levels. We will show you how to get to that next here, but some of the highlights of that document are just the blood product transfusion documentation recommendations, recommended schematron rules. There's the national required data elements in there, suggested benchmarking metrics, and data reporting and benchmarking sections. Next here is how we're going to get to this from the NASEMSO website. I wanted to highlight here in the top right corner, you can notice that I'm not logged in, so this is a public document, but we're going to go to our banner here to councils and the data managers. We'll scroll down. We'll fit the button that says documents and resources. We do have lots of other documents and resources on here, but we are specifically looking for the blood product administration one. By selecting that, that would then become a downloadable page for anyone who would like to access this. And this has been widely distributed and downloaded many times already. Next video here is just once again showing that the same document is available on the NEMSIS website. So whichever one you're more comfortable with, I frequent both websites almost every day. So once again, using our NEMSIS website, we can go to using NEMSIS data, NEMSIS 101, scroll down, go past our annual meeting resources, data consistency, all the way down here to our state-specific tools. And at the very bottom, you will see the NASEMSO guidance documents, a few other documents in there, but specifically for today, we will be looking for the NASEMSO blood product administration. So those are the same documents. Doesn't matter where you get those resources from. So I would recommend downloading all of them and having them. And that's all for me today. I think we'll be moving to Kevin next.
Yes, thank you, Randall. Thank you, Jeremy. I am sharing my screen here. All right, so I'm going to go over some of the tools and resources that are available at the NEMSIS TAC that are hosted. Most of these tools were in development with NHTSA and NASEMSO as well. So to start off with, let me kind of cover some of the things that we're going to be talking about today. So we worked on some algorithms to identify patients that have a potential need for pre-hospital blood. We are just about complete with a MVC, a motor vehicle collision, our motor vehicle crash algorithm. We're moving into an all injury algorithm, and we'll be expanding to try to identify all medical patients. We also are taking that algorithm and mapping that on a map of the United States so that we can see kind of where regions, counties, things like that have the greatest need for a pre-hospital blood transfusion program. We'll cover a annual report that has just been released regarding some descriptive statistics about pre-hospital blood transfusions. We're also we'll probably breeze past the custom elements. Randall just covered that really well. And then we're also going to show some things that TAC can do to assist you in identifying those counties, similar to what Jeremy mentioned. So how do we figure out who needs a pre-hospital blood transfusion? So the Pre-Hospital Blood Transfusion Coalition created a white paper, the clinical practice guidelines for EMS, to identify patients that need a pre-hospital blood transfusion or potentially need a pre-hospital blood transfusion. And so a lot of those elements are some of the elements that organization, the coalition, developed are with either optional elements or local or state only elements. So we really had to kind of adapt our algorithm to meet the national required elements. So you'll see here we have this kind of layman's guide for potential need for pre-hospital blood transfusions within a motor vehicle crash. And so the first thing we do is we made a subset. We're focusing only on 911 scene responses. So we've removed interfacility transfers, focusing on injury codes that match with our motor vehicle collision criteria. We've also excluded the EC08 that meets any type of hospital, so that in the event that a hospital calls 911 for an interfacility transfer or an ER to ER transfer, we've done our best to remove those, because we really want to think about who pre-hospital 911 responses could benefit from that. We also have some different criteria for adults and pediatrics, but essentially the adult criteria is systolic blood pressure less than 90, or a heart rate greater than 120, or a shock index, which is heart rate divided by systolic blood pressure greater than 1. And these vitals are anytime during the response. And then we adjust it for ages. For pediatrics, in this case, we're looking at pediatrics as age 1 to 14. And for the different age groupings, we've adjusted those as well. And so then once we get past that part, we then look at physiological criteria. So instrumentation, so anyone that's not alert in the APVU, or a GCS greater than or equal to 1 to 13. So when we look at through that, we also want to make sure that we're not including intoxicated or patients that we believe have a head injury. So we've gone through a list of ICD-10 codes, and we removed all these different ICD-10 codes that are listed for in the primary impression or primary symptom that cover intoxication or the head injury. And so you'll see there's also 2 of them that are crossed out. Skin condition and capillary refill are not recorded at the national level, so we've removed those. And then we include tachypnea, and that's adjusted for the age of the patient in years. And then we also have some end-tidal CO2 measurements. So we've taken all of these into account, applying them at the national level, and that's how we kind of come with our algorithm. So how do we do? So we're looking at our sensitivity and specificity. So our sensitivity, essentially it is how many people, according to this algorithm, what is our potential, who could potentially need blood? And of that, how many of that population, how many of those individuals receive blood? So we're saying we're running about a 54% sensitivity, which is pretty good. But more importantly, when we look at the specificity, so we say, okay, this is basically think of also maybe heard false negatives, right? So we think about who, of all that population, who was not a potential and who did not receive blood. So our specificity is 95%. So basically 5% of those patients received pre-hospital blood that didn't meet our criteria for documentation at the national level. That doesn't mean that was an inappropriate use of pre-hospital blood. It just meant that at the national level, that criteria wasn't, we're not able to pull that case out based on the national elements. There could be some state specific elements, or there's some documentation in the narrative that we don't receive at the national level. So now we have that algorithm, we've applied that to a geographic map of the United States. And so we're able to identify in 2025 across the United States, the continental United States, there are in 2025 there were 33,000 911 ground responses to motor vehicle crashes with patients who met the criteria for pre-hospital blood. So across those 3,000 counties. And so we took that 3,000 counties and it averages out to about 10.8 responses per county. So now we're able to look at this map and say, and chart those counties and say, basically, based on the national average, is that county above or below, and how much? You'll notice there's some white spots there. We did have to suppress some counties for small patient population or some transitions of 3.5 to 3.5.1 and 3.4 data. But we're able to see on this map that there is a significant need in different areas. Yeah. So in addition to that map, we've also created this resource. This is the annual blood transfusion reports. This covers 2024 to 2025. It's multiple pages. QR code will take you to the link where it's hosted. It's a PDF document you can download. So you can see that in 2024 to 2025, there were 48,000 activations in which pre-hospital blood was documented. And I do want to highlight that this may not be inclusive because, with that NASEMSO guidance document on how to document, that's the goal is for us to find all the blood, right? So we need to see it documented in a national elements correctly, not just in like on a custom form, but we're able to truly track how much blood is being given. So 48,000 were documented responses across all of EMS, interfacility, 911 response, air medical, etc. So like I said, this is multiple pages. Here's 2 more pages that really highlight 911 ground response. So we've removed interfacility transfers. We've removed air medical. So really highlight the statistics on kind of some statistics on how the blood's being administered, what type of blood product is winning. This document was emailed out on our listserv last week. It's going to become quarterly, available quarterly. So get it on our email list. We'll get it sent out to you. It also hit our social media platforms, LinkedIn, Facebook, and others. So if you're not following us, give us a follow and you'll be able to see these. This QR code will also take you to it. This is that PDF or that guidance document that Randall was just talking about. QR code will take you to that, but he did a great job, so we'll go right past that. Jeremy mentioned identifying counties with the greatest need. So obviously with data use agreements, we're not able to release publicly release counts of states and counties. So I have that area grayed out on this slide, and this is just a snippet. But with the approval of your state EMS director, we can work with you to help identify counts of MVCs, severely injured, if they're getting blood, essentially help you identify the greatest area for need. So if you're interested in applying for those SS4A grants or other opportunities to truly identify where you can implement pre-hospital blood programs, the NEMSIS can help you with that, and we'd love to do that. We have these items and the abilities to work with you on all of those items to really help and partner with you in NASEMSO and NHTSA to increase the prevalence of pre-hospital blood so we can increase pre-hospital care and decrease that 41,000 with the goal of reaching zero eventually. So that is where we are right now. There's still a lot coming down the pipe. Like I said, there's more algorithms coming. We have developed an internal dashboard for NHTSA and stakeholders to utilize. The goal, we're going to be working on developing a publicly available dashboard that shows pre-hospital blood administration, similar to our ONDCP dashboard that'll be available open to the public. So just keep in tune for those items. And what you see is there's a QR code that'll take you to the help desk. If you have any questions, you can email us, fill out a help desk ticket. It'll get routed to us. If you want to work with us to help to come up with those counts for those counties and things like that, if you're a state official or a local official, we would love the opportunity to help serve you in that way. I'm going to stop sharing. I think that there is thank you, Chris, for putting that link in the chat. I think that is all I have now. Are there any questions or anything further? Feel free to use the Q&A tool. If you click the three dots and you click the more, there's a Q&A portion if you have any questions, or I think you can raise your hand as well. Okay, hearing nothing, I believe that is it for our public training today. Randall, Jeremy, do you have anything to add before we wrap it up?
Yeah, I would just say thanks again for joining, and please reach out, as Kevin mentioned, reach out directly to the NEMSIS team if there's something they can help you with in terms of the data that he presented on. And I think if you're thinking about SS4A, applying to SS4A, and you've got questions, you can reach out directly to them via the SS4A email that I provided, or their website. Of course, you can always email me or anyone in our office, and we can do what we can to we'll do what we can to help you as well. So please don't hesitate to reach out to us. And if you've got any other questions or concerns, you can reach out to us anytime about anything. So thanks very much, and hope everyone has a good week.
Thanks. Looks like LJ, there's a question. Do you want to type that in, or? Okay, you're going to shoot over an email. Okay, perfect. We'd love to assist you in any way we can.
Awesome. Thanks, Kevin, and thanks everyone. Thanks, Jeremy and Randall. Also, a big virtual round of applause for our presenters. This is great information, and as they said, that contact information is always available. If you didn't get a chance to get those messages, if you'll hit the NEMSIS.org website in the scrolling all the way to the bottom of the page, there's a big red button that says submit a help desk ticket. That is always your best way to get in touch with anyone in the NEMSIS TAC. When that comes around, we route it to the person who is most available and best suited to answer your question. So please make use of that. It also gives us a chance to track it and make sure that you're getting a timely response. Once again, if you'd like to get notified about this and many other events that are going on with NEMSIS, please feel free to also use that submit a help desk button to sign yourself up for our mailing list. Find us on all the relevant social media sites. And thank you so much for attending today. Hope you all have a great rest of your day. Thank you very much.